Good morning, everyone. Thank you very much for joining us for our clinical update and grand rounds this morning. I think we have an interesting topic as it relates to CT angiography and its place in the diagnostic of coronary disease and sorting out patients with chest pain. I want to welcome our team. First, I'd like to welcome back Dr. Nezar Falluji, who is our Assistant Vice President at CommonSpirit Health of the Cardiovascular Service Line. He's an interventional cardiologist who practices in Lexington, Kentucky, specializing in structural, coronary, and peripheral vascular interventions. He's part of the CHI St. Joseph Cardiology team and the founding member of the CHI St. Joseph Medical Group there in Lexington. And he's also the medical director of the structural heart program there. So welcome back. And I'm feeling bad that I didn't put my bow tie on this morning, but I think Dr. Falluji is an excellent representative of the bow tie world. So thank you. Next, Dr. Juan Plana is with us from the Cardiovascular Service Line at Baylor St. Luke's Medical Center, where he is the chief of the service line and the Don W. Chapman Chair of Cardiology and a tenured associate professor of medicine. He is certified in cardiology. He earned his medical degree in Bogota, Colombia, and did all of his postgraduate training, internship, residency, fellowship, and chief resident year in cardiovascular disease and cardiac imaging, including electrocardiography and echocardiology and nuclear cardiology at the Baylor College of Medicine. His academic career started at the University of Texas MD Anderson Cancer Center, where he served as the director of cardiac imaging and the medical director of the echocardiology lab. From there, he was recruited to the Cleveland Clinic, where he opened and served as the co-director of the Cardio-Oncology Center. His clinical research and interests include cardiology as it relates to oncology, valvular heart disease, diseases of the aorta, and advanced cardiac imaging. Just to give you a sense of how busy, I want to say how busy this guy is, how busy Dr. Plana is. He's had 71 published reports in the peer-reviewed literature. He's authored expert consensus, multimodal imaging evaluations for cardiology complications of radiotherapy in adult, and most recently chaired expert consensus for multimodality imaging evaluation of adult patients during and after cancer therapy. He's had 200 invited presentations at national and international conferences and has been invited service to 5 journal editorial boards. Last, I would just say he's won major teaching awards from the Baylor College of Medicine, the Texas Science Health Center, and Cleveland Clinic, where he won Teacher of the Year and the Teacher of the Year award in cardiovascular medicine. So I think we have a lot to look forward to. And Dr. Plana, thanks. It was great visiting with you just before we started, and we're looking forward. So John, are you going to show the slides for Dr. Plana?
Gary, thank you so much for the invitation, and Nezar, thank you so much for giving me the opportunity of being with you guys today. I think that we are going to be reviewing a very interesting article that was just published in the New England Journal of Medicine, really addressing a very timely topic, CTA versus invasive coronary angiography in the patient that has a stable chest pain. This is on behalf of the DISCHARGE trial group. So what is the background? The background is that cardiac catheterization is the reference standard for the diagnosis of obstructive CAD, and it enables coronary revascularization during the same procedure. The problem, as we all know, is that it has the possibility of major procedural related complications. And the part that is suffering is that when we take a patient to the cath lab over here in the United States, we only find evidence of coronary artery disease, depending upon the source of information that you look for, in 38 to 50%. So in few words, for every patient that you take to the cath lab, in 50% of the cases, you are not going to find CAD. Pretty much you lost your trip to the cath lab. Now, CTA may rule out coronary artery disease. It's a non-invasive procedure, and it has a low risk of adverse events. And very interestingly, it will identify patients who are actually appropriate candidates for coronary revascularization. The PROMISE study showed equipoise between functional testing and anatomical testing. I think that we all train with the premise of using functional testing as a way to look for coronary artery disease. At the beginning, there was a little bit of uncertainty as to whether anatomical testing would be as good as functional testing. The PROMISE study put that concern to rest. It is as good as functional testing, if not better. So what is the aim of this study? The aim of this study is to compare shoulder-to-shoulder CT with cardiac catheterization as an initial diagnostic imaging strategy for guiding the treatment of patients with a stable chest pain who were referred for cardiac catheterization. The endpoint that was used in this population was a combination of cardiovascular death, non-fatal MI, and non-fatal stroke. So the way in which they did it is it was a multi-center, pragmatic, randomized superiority trial to compare CT with ICA. They included patients that were at least 30 years of age, that were referred for cardiac catheterization in 26 centers. And very important, these patients, based upon risk factors, were considered to have an intermediate pretest probability, somewhere between 10 to 60%. The exclusion criteria were patients that had hemodialysis, that were not in sinus rhythm, or that were pregnant. They used a 64-slide CT, and the study was interpreted by a level 2. They needed to have a level 3 as member of the imaging facility, but it was not required that the level 3 will interpret the study. So you have over here the results of the study. At a median follow-up of 3.5 years, you have on top your major adverse cardiac events. You have 38 for the group that had CT, a total of 1,808 patients, and you had 52 for 3% in the 1,753 patients that have the invasive coronary angiography. As you can see, the 95% confidence interval was 0.7, but you gotta pay attention at the ranges, and the ranges goes from 0.46 to 1.07, so it's crossing the boundary of 1. So as a result of that, you know that this is not gonna achieve a statistical significance, and in this case, the p-value was 0.10. So this is probably the most important part of this presentation. There was no difference, no significant statistical difference in the major adverse cardiac events between the two groups. If you take a look at the individual components, non-fatal MI, non-fatal stroke, cardiovascular death, they all cross the boundary of 1. So again, no difference whatsoever in these 3 subcomponents of the primary outcome. Now, they did what they call the expanded major adverse cardiovascular events. And what they did in this composite is they included TIAs, and they included major procedural related complications. And when you do that, then the rate of events was 50 for 2.8% and 80 in the ICA group for 4.6%. The hazard ratio was 0.6, and as you can see, the 95% confidence interval goes from 0.42 to 0.85. So in this case, this achieved a statistical significance. This is not crossing the boundary of 1 that we mentioned. Now, when you take a look at the secondary outcomes, you have 33 that occur in the invasive coronary angiography and 9 that occur in the computer tomography group. Hazard ratio is 0.26. So this is no surprise that you are going to have less events in the CT group. And you see underneath the difference in non-fatal MIs, strokes, cardiac arrhythmias, and so on in this population. So definitely you have less complications, and obviously this is not a surprise in the group that you are not doing a cardiac catheterization. Okay, so let's talk a little bit about the results, because there are some things that are important. So the annual rates for events were actually fairly low for both groups, and that is something that kind of caused surprise to the authors of the manuscript, really showing even when you are taking patients to the cath lab, you know, the low rate of complications that we are having. Now, to no surprise, the frequency of coronary revascularization was lower in the CT group. You see over here the numbers showing that you are making a more educated decision. And then the part that I found interesting is that during the follow-up period, more patients in the CT group continue to undergo functional testing. So I think that it gives you a little bit of a flavor of still, despite the PROMISE trial, where you show equipoise between anatomic testing and functional testing, I think that the physicians still have a little bit of discomfort of not knowing, you know, the functional data, although we know right now that it's not needed. Now, very important, during the last 4 weeks of the trial, there was no difference in angina in the two groups, and the quality of life outcomes that were evaluated in the study were not different. What are the things that we need to discuss? Obviously, there was no significant difference in the primary outcome. Fewer major complications and revascularization procedures for the CT group. No substantial differences in the incidence of angina. And the study really complements PROMISE and Scott-Hart that compare CT with functional testing in patients with stable symptoms. As I have mentioned before, and this is one of the messages that I want to leave, you know, our audience with, is that CT was as good or better than functional testing in this population. It confirmed the safety of CT, and very interesting, when you use this strategy, in only 22% of the patients in the CT group, you end up going for the strategy of cardiac catheterization. So I think that the question is how do we put it together? I mean, I didn't grow up with CT. When I was a fellow in cardiovascular medicine, we didn't have it. And sometimes it's difficult, you know, to incorporate technology that you didn't see during fellowship. But I think that CT right now has grown to be a very robust technology. I definitely use it in lieu of the trip to the cath lab in a population like this one, in the intermediate risk population. And right now, more and more, I am starting to use it as a replacement for my dobutamine or a stress echo or my nuclear stress test. I was discussing with Dr. McGinn that we actually have heart flow technology over here at Baylor St. Luke's. So when you add to the conventional CT angiography, the heart flow technology, you really get, you know, to sensitivities of 90 and also specificities of 90%, which I tell you, it doesn't get any better than this. So I anticipate that we are going to use it more and more. I was also discussing with Dr. McGinn. We recently this week reviewed the projections from SG2, and they go hand in hand with what I just mentioned. I mean, they have calculated that our rate of use of CT and MRI is going to go by somewhere between 40 to 50%, and the rate of growth for nuclear cardiology, estimated over here based upon the SG2 data, is 0.2%. So Nezar, what do you think? And perhaps we can start addressing the questions, Gary.
Yes. Dr. Falluji, comments?
So I think first I want to thank Dr. McGinn for picking up this paper. This is a very timely paper. And what Dr. Plana has mentioned, and thank you for a great presentation, Juan Carlos, is this technology is here to stay. It's of a significant value. I think the first piece of information we get out of this trial is that events rate are very rare in the stable coronary disease patients. So in the ambulatory setting, when you see a chest pain patients, they're not doomed to having a big myocardial infarction. And in fact, when we invented PCI and stent placement, it seems that we had a pandemic of unstable angina. We used to, back in the old days, treat a lot of patients with coronary disease and stable angina with nitroglycerin, and we didn't worry. But once we started to have PCI, there was a plethora of procedures. But I do like the idea that we have a technology now that does not have the ambiguity of nuclear imaging, which in a place like where Dr. Plana practices, the quality of the imaging can give you a decisive outcome. But the technology varies and the technologist's skills vary, and there is a lot of limitations and diaphragmatic attenuation, breast attenuation, and motion artifact that makes it impossible sometimes to interpret the study. I'd say if the patient can get on a treadmill and walk, especially in that intermediate risk group, I sometimes actually bias the nuclear imaging to the performance they did on the treadmill, which already says something about the quality of the nuclear piece. I think having this technology, especially when you add to it what you've mentioned, Juan Carlos, the heart flow piece, which is the physiologic assessment, it is a game changer for that intermediate probability. And I talk too much, but I'll finish with one last statement. There is no substitution for the physician's evaluation. The piece is, everything we've talked about today rests on the pre-test probability. Does this patient have muscular skeletal pain, a gastrointestinal pain? Do they have the risk factors for coronary disease? Are they in the right age group to worry about coronary disease? And that's how we should guide our utilization of the technology.
Nezar, I want to touch a little bit on the discussion that we had during our National Cardiovascular Service Line meeting, where you mentioned the struggle that you're getting from some of the insurance companies in terms of approving the diagnostic angiogram. What is that they want? Do they want you to proceed with a CT? Is that what they want?
So they're, and I don't fault them for that. They would, so I think this technology is not to replace necessarily stress testing, but unnecessary caths. And so if you have a positive stress test, a lot of the times they're asking us to order a CT scan, a CTA, a CT angiography, instead of actually taking the patient and doing that invasive testing. It's more efficient. It's not invasive. It's actually more decisive potentially because not everybody is going to do an angiography and an FFR. There's a tendency to stent what looked or appeared significant. So I think that's the impetus for their position. I can say also that we do a lot of diagnostic angiographies that are not related to stress testing. So pre-TAVR, pre-mitral clip, we do these works, and now we can avoid the invasive procedure and say, let's just, because the intention of these is just to know if there is any pre-existing coronary disease before we go to TAVR and pace the patient at 180 beats per minute and give them acute ischemia on the table. And if you think of it, if we could just do a CT and eliminate the step around. So I think there is a push for that too. When you order a coronary angiography pre-TAVR, they say, well, why not a CT angiography? And actually, indeed, why not? We should just do that and move on. So I think there's going to be a shift. And I know that invasive or interventionalists like me worry about losing that business, but honestly, you're losing the diagnostic angiographies that are not meaningful to the patient, and it's just wasting your time. These tests are decisively going to detect significant disease, and they will need to go to the cath lab and get a more efficient utilization of resources.
But I tell you this, I mean, if you take a look at this data that we just reviewed, I mean, if I were a physician advising an insurance company, I think that it is difficult not to understand their point of view. I mean, you are only finding obstructive CAD in 37 to 50% of the patients that you're exposing to this invasive procedure. So I don't think that they are on the wrong, saying, why don't you take the patient to the CT suite, do a very fast test that takes seconds, a very low dose of radiation, and then get the answer. You don't have to stick the groin at all. And then I want to ask you another question, Nezar, and then I stop and then I answer the questions, from the group.
Questions, but sure.
I think that the issue that we have is also an issue of efficiency. Right now, I mean, we hear left and right, the struggles in terms of accommodating, the volume that we require in the cath lab. So I don't think that it's a bad idea that we trim all of these unnecessary diagnostic cardiac catheterizations, and that we really use the cath lab, to do meaningful percutaneous coronary interventions that are actually appropriate.
Absolutely. I couldn't agree more. I think the idea that you should take someone for, and you mentioned complications, and yeah, they're rare, but when they happen, they're catastrophic sometimes. It's a stroke, it's a retrobleed, it's a loss of a radial artery, those who get radial. So the value to the patient and the risk associated with it is just cannot be justified today. Now, yeah, 5 years ago, CTA wasn't really there, and we had issues. We still have some challenges in heavily calcified lesions and patients with multiple stents because it can't be overread. But you can be selective in those patients and say, I think the quality of the CT may not be good, and we'll do an invasive assessment. But just to do it for everybody because they had a positive stress test, to me, it's.
I really want to echo what you just mentioned, because I don't want people, to come up with a conclusion based upon our discussion that CT is good for every patient. I think that, just like you mentioned, you got to stop and think. I mean, in this case, they use patients, that had an intermediate risk of CAD, but we don't know, the amount of calcification. These are patients that do not have stents. So this is a very different population, because then if, for instance, in the patient that has significant calcifications, you end up struggling, with the blooming artifacts. And then I think that even with FFR, I don't think that we are there, for the evaluation of patients that have stents. They are working on that. I think that this is going to be the technology of the future.
Agree.
But for your regular patient that has intermediate risk, that doesn't have calcification, or at least you don't know it.
Not the majority.
The majority, right? And that do not have stents, I think that the technology is just great.
So a couple of questions have come in. This is a great conversation. One we talked about before we came on live, and there was a question about concerns about the contrast shortage, and that may be invisible from where you sit, but we get in the literature that there's a contrast shortage, and we have to be really careful. But frankly, I don't want to answer the question, but it seems to me that you need contrast for coronary angio and maybe less contrast for this. And so is that the case?
Well, I mean, definitely you need contrast, for your CT angiography. The only situation where you do not need contrast, and this is a separate discussion, is if you are calculating your Agatston score. This is a population that is different, and the question that we are answering is very different from the one that was presented in this New England Journal of Medicine. I think that this is a problem, because we are really using CT more and more. Just like Nezar mentioned, CT is our working horse right now for the evaluation of the structural heart disease patient. So yeah, that's an issue.
And is the volume of contrast different between an invasive procedure and CT?
So right now they are very intelligent, in the way in which they use these protocols. I don't know exactly where you compare shoulder to shoulder, Nezar. Perhaps you know the answer, in terms of the exact amount of contrast that you use, but it all depends on how the study is protocolized. I mean, it is very different, if you are just evaluating the coronary arteries versus you evaluating, the aorta also in the setting of a pre-TAVR study, chest, abdomen, and pelvis. So,
Yeah,
Nezar, any comments about?
I agree with you. I think the protocol determines. So, Gary, there is a preset amount in a CTA. We can definitely do with less in an invasive assessment. So I can look at both coronary arteries and walk away with 10 cc's of dye if they look normal.
Yes.
And be very strategic and say, take one shot of the right coronary, it looks great. And I see an issue in the circumflex. And I say, well, now I'm going to take 4 shots of the circumflex because I'm trying to determine, and I'm still going to be less than a CT because the CT is a protocol.
Yeah.
I do think that's when the kidney function comes into play. Also, hopefully the contrast shortage is a temporary thing, but we still look at the patient's kidney. And I, as I said, we have to be thoughtful about how we use these technologies. But in the grand scheme of things, if all things are alike today and there is no shortage, certainly this CT is superior. If you have shortage in contrast, invasive assessment can still be more judicious.
Can I, this is Tom, and I apologize for the background noise. Is it so bad that I shouldn't be on?
No,
or is it okay?
Fine, Tom.
So I'm going to sneak in my one question here. Sorry to cut you off, Gary. Let's step back a little bit from a macroeconomics and process standpoint. How does this play itself out over time? Because, we're always resistant to change in healthcare. We have cardiac cath labs, in various sites. There's a fear that, this could supplant cardiac cath labs in some fashion. If you, not supplant it, but at least reduce the need for it. Therefore, that would be resistance to adopting it from an economic standpoint. Am I making sense? In other words, there'd be resistance to do more CT angios because you're scared that might reduce the cath volume. Now
Yes. So I think
is that a resistance that we could anticipate? Health systems are slow to change, to adopt, because it's, there's a lot involved in making those changes.
So I think the good news is technology is profitable and health systems will have to do that. I think the value to the patient, I think the payers are going to be a force to be reckoned with. They will force this narrative, and health systems are going to have to invest in this technology. This is no different than the conversation we've had around TAVR taken away from cardiac surgery, and cardiac surgery being the more profitable procedure, but we're losing to TAVR. And the reality of it, technology will continue to evolve. It will increase efficiencies. It will bring more value to the patients, and we have to get with that. I think Juan Carlos can speak to the financial implications better than we do, because actually we don't have it yet in Kentucky. We're putting the CTA here in our facility. But if I'm not mistaken, Juan Carlos, this has not been a financial loss for institutions that had a good protocol. If anything, I would argue it's very efficient and very profitable and good for the patient.
I agree. And I agree with you 100%, Tom. I think that there is going to be hesitation. Dr. Falluji knows my crew very well over here in Houston. It's a crew that is not known, for non-invasive testing, if we want to put it like this. Diagnostic cardiac angiography was the bread and butter, of every physician over here at Texas Heart Institute. I think that what is going to make us change the way in which we practice is actually the insurance companies, just like Nezar was mentioning. You can schedule your patient for a diagnostic cardiac catheterization, and then you're going to get the unfriendly call from the insurance company saying, we are not approving it. Get a CT scan.
Yeah. I think that, and I don't, this is not a judgment on people. I think it takes time to change the process of care, and it will take time. And you're always better in front of things like this once the evidence is clear, because I think the evidence is very clear at this point.
That's correct.
As opposed to resisting it, it's always better to be part of it and push it forward. It's better for the patients. And at the end of the day, it's just going to happen because it's the right thing to do. And we will be in front of it. I am confident that CommonSpirit will be in front of it, and so will you guys. But it just change is hard.
Right. It's efficient.
I fully agree.
Yeah, I think it's efficient, and that will, people, wow, I could save an hour. So there's two other questions. One is, could you talk a little bit about heart flow technology, and will it become more standard in these patients? And the question I have is, does that help with valvular disease, heart flow technology? So maybe you could talk a little bit about that. And then the second question was, could you describe technological needs to do this CT software expertise and cost to upgrade to be capable of performing CTAs, that sort of thing. So I don't.
Sure. So so perhaps I can actually take the two questions together. Sure. So the way that heart flow works is as follows. You upload the information from your CTA angiography into a server that connects. Over here for Houston, there are two possibilities for analysis. One, they actually have a facility nearby Austin, Texas, and they have the main one in the Silicon Valley. But when you take a look at the facilities, those are facilities with supercomputers, because there is a lot of very complex mathematical analysis that go behind the possibility of doing FFR non-invasively. So right now, although I think that this is the way of the future, that we will be able to put this technology, inside a regular PC, that's not a reality. Right now, the data needs to go to the Silicon Valley or to a facility in Austin. It needs to be processed by these spectacular, super duper computers, and then they bring you back, a very friendly report that is color coded, with your FFR. So in terms of the technology that you need, all what you need is a well-done CTA angiography, and then you will need the server that is connected, to heart flow. The financial models have changed. Initially, they wanted the facilities to pay. Right now, they are taking the risk. If they can build, the insurance company, then this is how they will be paid. If the insurance company doesn't pay, they actually swallow the cost for the heart flow. Now, addressing your question for valvular heart disease, does it help? No. What heart flow does is it really creates a way of calculating your a fractional functional reserve non-invasively, kind of in a way that is analogous, and it has been validated. Dr. Falluji, crossing the lesion, measuring the pressure distally, measuring the pressure proximally, and dividing it by the distal pressure. I don't know, Nezar, if you have any comments about that.
I just always assume that people don't know what FFR is, so I'll just touch quickly on that we frequently see blockages that we visually would like to believe are very tight. And when we put this hemodynamic pressure measurement, so it's a wire that has two transducers. If there is no significant drop in the pressure, then we know that what we think is tight is not tight, and it should not be addressed with a stent. And that's about 30% of what we interventionalists think. So based on the literature, about a third of these lesions that we deemed high risk or needed to be fixed did not need to be fixed if you do FFR. And what Dr. Plana is referring to is a replacement for that invasive technology that you could do through the CT. So this is an amazing disruptive technology, in my humble opinion, because it's taken us away from worrying about lesions that can still look tight on a CT and saying, well, it looks tight on a CT, but just like with the angiography you guys do, hemodynamically, it wasn't significant, so it should not be addressed.
What happened historically before, the beginning of FFR is that the interventional cardiologists, and I don't mean to give you guys a hard time with that, had what we call the oculostenotic reflex, you know? They saw a lesion.
We all have it.
Exactly. I mean, and it looked tight. So let's go and put a stent. And then
it's my favorite ophthalmologic condition. We all have it, but certain specialties have a little more, I have to say. But that's just the general internist speaking here. So
exactly, we're genetically predetermined to be that way, Tom. We don't have any.
But I tell you this, I mean, with FFR, that went away, because right now we know that even if the lesion looks ugly, you put a wire across, and if the FFR is north of 0.8, the patient will be fine. So imagine if you can do that, in an analogous way with a CT scan. I mean, you go, the radiologist will tell you, oh, you know what? I mean, it looks like 50 to 70%. Perhaps, you need to take a trip to the cath lab and stent that lesion. But you say, no, hold on a second. Let me upload the image, to HeartFlow. And in 2 to 3 hours, they will give you the result. And they tell you, that the FFR is 0.90.
Yeah.
You're done. You don't want to stent that lesion.
Yeah. I have two last questions.
So, yeah. I guess my question was going to be that as a general internist, right? Like at the end of the day, when I have my patient in my room and thinking about clinical standards and how do we bring this technology across the board judiciously, what are the 1 or 2 things that you want internists and family medicine docs, primary care docs to talk about in that patient room with their patient before we send them over to you, especially when we're considering invasive versus non-invasive technology?
So I think that probably the most important thing that you gotta consider is going back to the first class, and I think that Tom is gonna like this, of what is your pretest probability. Because when you are sent, if you have a low pretest probability, the patient has chest pain but is 20 years old and doesn't have hypertension and doesn't have diabetes and doesn't have hyperlipidemia and there's no family history, the chance that you're gonna find something, is very close to 0. And these are the patients that will not benefit, from stress testing. You gotta do a good job, in the assessment of the risk, and when you do a good job and when you really end up calculating the patient that has in the intermediate risk, these are the patients that will benefit, from getting a non-invasive evaluation. Now, on the contrary, if the patient has a high risk, you have calculated your pretest probability and your pretest probability is 95%, this is a patient that probably needs a trip to the cath lab straight, without wasting any time or any resources, in non-invasive testing. So I think that going back to the basics of your pretest probability assessment is golden, in your office, in the office of the internist or the family practitioner, in terms of how you sort out these patients.
My music to my ears, doctor. Thank you so much.
Very good. That was going to be one of my questions. So excellent, Dr. Sagar. But now there's still 2 questions. So, but I think one, Dr. Falluji, for you, how widespread and available do you think CT angio is in CommonSpirit facilities?
That actually depends on the divisions. In the Southeast division where we are, it's not very common, but we're shifting. We're going in that direction. It is fairly widely spread in Arizona and the California divisions, in Texas, in the Southwest. You might need to find the facility that does that for you. And to be frank, for years before we had it here, I've used, well, not for years, but at least for the last year or so, we've used a competitor just because that is, again, as I said, the right thing for the patient. So the university is next door and I would order it there. So it is there. The technology, as Dr. Plana stated, is out there already. It's approved by insurances. It's FDA approved. The evidence is behind it. It is the right thing to do. And most of our facilities, larger facilities, has it. But if they don't, then obviously you have to resort to a competitor potentially.
Okay, great. And we can, Dr. Plana, you can probably answer both of these together. One is, what studies have compared CT FFR with catheter angio FFR, and how accurate is CT compared to catheter angio? And the last one is, someone asked, what is the scoring system you're using to identify risk?
Sure. So, addressing the first question, the data that we have is that the sensitivity specificity is about 90 percentile. So it's pretty good. I mean, if you compare, echo or nuclear, there's not a way on earth that you're going to get, to these levels of sensitivity and specificity. As you know, depending upon the modality, you can be either sensitive or specific. If you want, historically, if you wanted to cath a patient, you will order a nuclear because it would be very sensitive, and just like it was mentioned before, you have, all of the limitations in reporting. So they will present to you the breast attenuation, the diaphragmatic attenuation. So patients will go to a cath lab and a stress echo will be more specific. In terms of the risk scores, it all depends on where you are seeing the patient. We didn't talk at all about, the sorting out the patient in the emergency department, but the same principles apply. We like the heart risk score. If it's less than 3, patient needs to go to their private cardiologist, no need to stay in the hospital. If it's from 3 to 6, you stay for testing. I think that a CT scan would be great. If it's north of 6, you gotta go to the cath lab. And then outside, just your conventional stratification of risk, paying attention at your risk factors, age, family history, hypertension, diabetes, hyperlipidemia, smoking, and presence or absence of findings in EKG.
Right. This has been a fascinating 45 minutes, and I think very valuable for the folks on this call and for the folks who will listen to this. And I just want to thank both of you, Dr. Plana and Dr. Falluji. And Dr. Falluji, thanks for organizing and triangulating with Dr. Plana. This has really been just a wonderful conversation, and I think it'll be really helpful to all the providers at CommonSpirit. So we thank you. And Tom, we thank you for finding this article. Really a great morning and really appreciate it.
Great to have a diagnostic discussion.
Thank you.